You guys look very serious.
Dropping in. Hello, everybody. Welcome. We're just going to give everybody a minute or two to join our conversation.
We need some background music.
We do.
No, we need something.
Anybody got a TikTok dancing video?
Garrett may.
Yeah, right.
Okay. You can put your kids behind you, Garrett.
I can screen share a college lip sync contest that a friend just sent me. That could be.
We'll wait just another minute. I'm seeing it fill up.
I actually think super.
I'm going to see people saying hi because I know they can see a lot of our faces, and we want to say hello to all of you who are watching and dialed in. Thanks for joining us. All right, well, it's 3 minutes just after 7, and we have a photo bomber. And I want to welcome everybody to this Zoom interview with 4 of our doctors acting as experts and a 5th, Lelach Rave, who's going to be moderating this for us. She herself is also a practicing physician. And I thank you for joining us and serving that role, both from your own perspective as an expert and helping pull out some really great ideas and insights from the other 4 doctors who are with us tonight. So I want to say thank you all. In these moments when we are transitioning to a new world and trying all different things in different ways and interfacing with each other in so many different ways, this is going to be a very informative panel and hopefully put many people at ease with new ways that they can think about interacting with their doctors and just how to continue taking care of themselves in this moment and in the sadly foreseeable future. So I want to thank you all for being here. Thank you to everyone listening and dialed in. And with that, I'm going to hand it over to Lelach Rave. Thank you.
Thanks, Amy. So we are all really excited to have you join us tonight. And our purpose this evening is to really explore a new way of providing and receiving healthcare. And what has happened in the last few months has really been unprecedented. There was talk about telehealth before the COVID pandemic, but the change that has happened in the last few months typically would have taken at least a decade. And so in this rapidly changing scene, we thought it may be useful for you to hear from some folks who are interacting with telehealth daily. Hopefully you're not, those of you who are dialed in, interacting with your doctors every single day, but those of us who are practicing medicine in this way are getting accustomed to this brand new scene and learning as we go, as we all are. And so hopefully we'll be able to shed some light on what we've gained from our experiences doing telehealth, and it will hopefully make your experience of gathering healthcare a little bit more comfortable, a little bit easier, and feel a little bit more familiar as you engage upon your healthcare. So we have 4 really great folks who are with us. Dr. Garrett Hyman is a sports medicine physician. We have Dr. Phil Moberg, who is a rheumatologist, Dr. Don Shifrin, a pediatrician, and Dr. Wendy Spektor, a dentist. So all very different perspectives and different realms of the healthcare world. And Garrett, since you're the one who came up with this idea of this great Zoom conference, I'm going to let you kick us off and talk a little bit, if you would, about how your practice has changed and maybe what surprised you in a positive way about telehealth.
Absolutely. So a little bit of background, because I was asked to mention, like, why I reached out to Amy Lavin about it. Just a few weeks ago, I participated on a panel through the Washington State Medical Association where they were trying to help physicians troubleshoot the new world of telemedicine. And after that, I realized, well, it's a brave new world for patients as well. So that's where I thought our community here might benefit from chatting with a group of physicians. I had my first experience with telemedicine probably about 2 years ago, because in my practice, which is situated in Bellevue, or in the heart of, as we all are, we see all these tech workers, and I had people who were traveling a lot for work say, well, can I follow up with you to review these MRI results in another way, like, through a, FaceTime, Zoom, or something else. So I found a HIPAA compliant, for privacy laws, a HIPAA compliant service that I'm actually still using today called Doxy. And I had a couple of these visits over the last couple of years. So then when this came on, I had at least a framework for how to do it. Although I'd only done these kinds of follow-up visits where it's specific to review like a test result. So I had not done it full on as we started to do as of March 17th. So I practice, I have a small practice, 2 doctors in Bellevue. I practice non-operative sports medicine. So much of what I do is try and come up with a precise diagnosis to help people with musculoskeletal and spinal issues that aren't getting better with other kind of conservative care, like physical therapy, massage therapy, acupuncture, that kind of thing. So when they're not getting better, that's the best time to see me. So much of what I do really depends on seeing someone in person, actually, the physical examination. So my work, and this is the case really for everyone here in large part, but at least in my brain, I thought, like, well, if I can't see, I thought ahead of this time, if I can't see someone in person, I can't do a good job. So I had this real bias that I couldn't entertain seeing somebody with a new problem where I hadn't already examined them in the office. In any event, we went full on into the telehealth world as of March 17th, and including seeing new patients with new problems. And it has surprised me that I can get a fair bit done. I can give people useful guidance and certainly answer questions, and at least come, most cases, close enough to a visit that they might have in person. Although there have been several exceptions where it's clearly worse, and I've told them I'm going to need to see them in the office, and we'll let them know when we open, that kind of thing. So I don't want to keep the floor, but that's a little introduction.
That's a great introduction. Thanks, Garrett. Phil, do you want to pick up from there and give a little bit of background of how you've seen your practice change and what has pleasantly surprised you about engaging with telehealth?
Sure. Yeah. So my work setup is a little different than Garrett's. Though Garrett and I do share patients because I do rheumatology, which is also overlaps with musculoskeletal medicine. But I'm one of the, especially as of January 1st, I'm part of University of Washington. So we're situated at the Northwest campus. So that's one of the UW's newest acquisitions. And so I'm part of a big, huge system, and we have, well-established multi-tens of millions of dollars electronic medical record system, and which now piggybacks using Zoom, the same technology that most of us are using for this conference. And, so we have IT support supposedly, but we have a big office with, 7-10 providers and 20 support staff, and a couple of the support staff, thankfully, are IT savvy. So that's made the transition a little better. With rheumatology, there is a lot of physical exam, but I also do a lot of things, which is mostly with medicines. And so if those kind of things of counseling about medications, risks, advantages, that easily facilitated on telemedicine. And that's worked well. And that's probably been a surprise for me. That's worked better than I thought. Unfortunately, a lot of my medications, I do need to monitor lab work. And so obviously can't do that through telemedicine. So like Garrett, there's just situations where it can't work perfectly. And they have to make contact with the clinic at some point. So we're, after now 3 months of this, lab work is due in a bunch of my patients. So we're now doing a mix of telemedicine and face-to-face visits and trying to keep populations in the waiting room low by interspersing telemedicine. And since there's 7 doctors and 3 nurse practitioners and a nutritionist in our office, we have to be careful about how we build those templates for who can come in to see us face-to-face and who can use telemedicine, so we keep the waiting room population low and people can socially distance within our waiting room, which is a decent size, but of course it's not infinite. So that's a little bit of a different perspective. And for a while there, I was about 90% of my visits were telemedicine, and I'd say they're about 70% still right now. And honestly, if there's no reason for the person to come in, they don't need labs, they're not complaining that their knee's swollen and needs to be examined, then I just prefer telemedicine for everybody's sake.
Thanks so much, Phil. Don, do you want to share your thoughts?
Well, if you consider telehealth as healthcare delivery, which is now mobile applications and virtual visits, pediatricians have been doing audio health for decades, because what we did in the old days and what we still do is we conversed with patients on the telephone about a variety of illnesses or questions. So we were doing telehealth before 2007, and there was an iPhone in 2010 when the iPad came into existence, and been with us for about 10 years now. And then we were getting pictures, and we were getting requests to do FaceTime with patients about behavioral issues, but because it was not HIPAA compliant and still isn't, we worried about privacy issues, which are now taken care of with Doxy and other mobile applications like Zoom, which hopefully is private. Our office now uses Zoom, and there's been some barriers, but pediatricians have been discussing this since telehealth started back in the hospitals 2014, 2015. We knew it was coming, but we still weren't sure whether patients would prefer a virtual visit over an in-person visit because of the tactile sense of being able to see people's faces and judge their responses. So obviously this is a more efficient way of taking care of things that didn't require an in-person office visit. Behavioral stuff, nutritional, checking on allergies, asking questions from doctors on development, and almost also illness. We've had a number of questions about illnesses. Some we can deal with on a virtual visit and some we can't. And that's the definition of triaging, which sometimes happens during a virtual visit too. So the pros here are certainly it's an effective way of delivering care for a number of things, but not all things. And so pediatricians are excited about it. Patients have embraced it as a way to engage with their doctor without waiting 20 minutes in the waiting room with other patients who might be sick, driving 20 minutes in traffic, et cetera, et cetera. So there's been some great embracing by patients. So I don't think we're going to go back. I think we're going to see this, as Lelach, you can also verify and validate. We're going to see this even after, hopefully soon, the coronavirus crisis ceases to exist, which may or may not happen soon. So I'll stop there, and we can get into documentation and all that other stuff in a few minutes.
Thanks. Wendy, you ride a different horse than the rest of us in the dental world. Tell us how it's working there.
Well, March 13th, we never went back to the office. So my phone started ringing March 13th in the PM and didn't stop ringing. And so we really had to figure out something, because I had really fantastic supportive help. I did not choose to go in the office, but had all kinds of specialists on call. But what that meant is that I really had to triage my patients. And I've always triaged patients. And when people were hurt, they called whenever they needed to. So dentistry, the problem is you really can't do it over the phone. However, you can diagnose or at least triage and give some scenarios and then figure out where someone's supposed to go. And that is what I did for my patients. And I have had people who've fallen on their face and broke their front teeth. And what do we do with that? And I've had people who say, I broke a tooth and I'm dying. And I say, okay, take a picture. So this little device has changed really all of medicine in the fact that you can take a picture, you can pull your cheek out. I told one person how to hold the camera and they took a fantastic picture. And really, I got them to where they needed to go. So I think that there is going to be teledentistry. It will probably work best with orthodontists because they may actually be able to do treatment over the internet. For general dentists who need to numb people and take care of problems for people's teeth, they're still going to have to go to the dentist, but they will be able to communicate better through teledentistry or through their phone what the problem is. And I think that that has been utilized for the past 2.5 months very successfully. And it's been really nice to work with your colleagues and to solve people's problems without them even having to come in right away. And I think that it's very encouraging, and the more that we're on our phone, the more I know that things are gonna, I know people who are diabetic that have all of their medicine on, they know what their levels are. I know people who want to refill their medicine. They don't have to go to the doctor, but they can have a conference with a physician, which is fantastic. And I think the future is here. It just came like in 3 months. So thank you.
Yes, it did. It came very quickly. I will tell you, one of the things that has surprised me is how delighted people in quarantine are to see a face over the screen that they know and feel comfortable with. And it has also been really lovely and delightful for me to see my patients on telehealth in a way that I don't think I expected. So with that, let's talk about what makes for a good telehealth visit. What is it that makes us successful as practitioners, and what is it that our patients can do to help ensure that success so that they get the care that they're needing and looking for? And I don't know, Phil, do you want to maybe start us on that one?
Sure. I'm not sure what would make a good, and for me, most appointments are pretty similar. I think the key component to making a good telemedicine encounter is patience. And I don't mean the people, I mean the quality in your mind to be patient about the whole process. Because it's a new process. Wendy said it well, is, they were estimating about a 2-year rollout for rheumatology to go into telemedicine, and that went away in about 3 days. And so we're not very good at it. We're learning a skill set as well as the patients are, and the technology obviously is, as Dr. Don worked with today, is there needs to be hard reboots of software and hardware and all that kind of thing. So so I think patience is a key thing, and I think that's probably what leads into some of our other topics is the success rate goes up much better when patients get out in front of the technology part and streamline their technology ahead of time, and typically work, at least in our office, with somebody to figure out Zoom, which is our software platform. But I've actually, this also sort of blends to your last question, is I think that these telemedicine visits have really lended themselves to being good right off the bat, because patients are more relaxed. They're in their home, usually. Sometimes they're in their car because they don't have good Wi-Fi. But there's not going to be the white coat hypertension so much, and so I guess I don't have a real clever answer for that, other than I think it's going to be a skill set that we all build up, and as Dawn said, I think it's here to stay. I can't imagine putting it back in the box at this point, especially for what I do. So,
Thanks, Phil. Do any of the rest of you want to comment on what you found has made it successful for you and your patients?
Well, I think when I talk to my pediatric colleagues who are actively doing it, the key is that obviously they have to have a great Wi-Fi connection so it doesn't break up, especially if they're identifying, looking at an examination of a child on video, whether it's a rash, whether you're looking at a child who appears sick. The connection has to be good. So I think that we have in our sort of FAQs for patients, the ability to really practice and use a good connection and try not to do that. But then again, it depends on the skill of the doctor in assessing the chief complaint and really listening to the patient and being able to get that patient to where the patient wants to be, which is sometimes a difficult chore, as you would understand, Lelach. So success is in the eye of both the beholder and the patient, I think. And sometimes when I was, seeing in-person visits, I thought the visit was a great success, and later on found out that perhaps it wasn't. Let's just put it that way. So I think it's a movable feast at best. But I think that what patients have to understand is they should have something to take notes with. And these are not recorded visits, unfortunately. There's no archiving them. And patients can't record them from their Zoom video. So we always encourage them to have paper and pencil handy and ask questions at the end. Doctors are geared to say, is there anything that you want to finish or continue that has to do with this child and not the child that's waiting by the door?
Great. Garrett or Wendy, anything more that you guys want to add to that?
If I may, I'll just point out that distractions will happen on both ends. We talked about this in the pre, before starting with everyone, but it's, I'll have one of my, I'm in my little office here, but I'll have one of my family send something to the printer, which is just adjacent to me, and that'll get noisy. Then they'll walk in, which, is usually it's an easy challenge to navigate. But it's, that happens on the patient end too. It's actually probably harder there because I think it's just me. Like I actually don't get distracted that much if my family is walking around, but sometimes, it depends on the person. Some people do get concerned if there's a child around, but the biggest challenge thus far has clearly been technical. We schedule in our office extra time. So like our normal appointments are either 45 minutes for a new patient or mine are 15 minutes for usual follow-ups unless I'm doing a procedure. But I schedule at least 20 minutes for even a routine follow-up and still 45 for a new patient. And so it takes, I have built in extra time. And that has come in very handy because people have to restart their machines. I've had many cases where the video conferencing simply doesn't work, and then we've gone only to regular audio phone, or like happened to Dr. Don earlier, where initially audio wasn't working. Sometimes I've used the video and called them on the phone at the same time, but there are constant technical challenges. And as luck would have it, I kind of upgraded my home Wi-Fi just as this thing was happening. And that's, gone well, I think, on my end, but it is just a constant challenge to keep a good connection. So, I guess I would overemphasize trying to plan in advance from the patient end to test your ability to maintain a connection. Love the idea Dr. Don pointed out about having something to write with, because that has definitely helped to make it a successful visit. One of the things that I'd point out that is really useful with the things like Zoom is we can share our screen. So if we're trying to explain something, whereas in the office we might grab a model or whatnot, here we can bring up like a pristine image from a quick Google search and share that. And so the ability to educate patients with pictures is, that's quite good via the telehealth.
Lelach, can I ask you a question? How long do your virtual visits are scheduled for? Ours are, the routine is 20 minutes.
So in my clinic, different physicians have the ability to schedule based on their own preference. So I see all my telehealth visits in 30 minutes. But everyone does kind of what they feel that they can handle with that. One of the things that you said, Garrett, that really brings to mind something that I'm seeing in my clinic as well is we're really seeing an issue in terms of health equities and the disparities growing greater with this technology need. And so families who do not have access to the Wi-Fi or the computers really find themselves somewhat at a disadvantage. And so at my clinic, actually, one of the things that's being done, and it's really being aimed at more of the older population because I'm in a multi-specialty clinic, not just pediatricians, is we actually have an iPad program that folks can come and park in our parking lot and have an iPad be brought out to their car, and then they can do a telehealth visit with the physician who's in the clinic. So
Okay.
they do not have the risk of going in and potential exposure to other individuals who are ill. But it's one way that we're trying to handle some of the disparities in terms of access to technology so that people can actually access telemedicine. So I think it's going to be another interesting area where things will evolve.
Well, I think the other thing that we haven't talked about, but is the fees for people coming in, because I actually think the dentistry will have teledentistry. And I think that it's going to be a new world for patients who, are they going to make payments, and how are you going to charge? And we need to do that if that's how our medicine is going to be delivered in the future, when we can deliver it that way. So that's a whole nother conversation about what are people expecting? Because I find that very interesting. And when you start a telemedicine conversation, what are they paying? And how are you paying? And how are you getting it? And those are all conversations for the future, because in our office, we don't even want to touch a card when a patient comes in. So these are many interesting questions. So I'm wondering how you're paying, how people are paying, where did you start from? Because a lot of us had to just start from nothing.
So a little bit of commentary on that. In this past legislative session, there was a bill passed so that as of January 2021, there is telehealth parity for medicine. I don't know if that applies to dentistry or not,
Okay.
but for medicine, there is telehealth parity that's mandated by law. Medicaid already has telehealth parity. So patients who are covered under Medicaid, their physicians are being paid the exact same way and the exact same fees that they were paid prior to the pandemic. And then Governor Inslee did issue an order for telehealth parity that spanned the first few months of the pandemic and then was not renewed. So at this point, telehealth parity does not exist for commercial insurance in the medical world. It does exist still for Medicaid. And I don't know if Phil, I don't see Medicare patients because those are the
It is for Medicare as well, because it's run through CMS, which does Medicaid and Medicare, and so that legislation does protect that going forward, which has made it straightforward. So yeah, Wendy, it's billing just like before, and if people have ways to pay remotely, then they're able to do that and not have to pass a contaminated credit card back and forth. So. But the commercial thing was, I think we were all waiting for that, and that was just recently that it wasn't renewed by Governor Inslee. So
right.
that will change the flavor, right? Because that was done emergently so that clinics could start making some of the lost revenue back and keep people paid and the lights on, et cetera. And for folks following the news, they can see in my institution, University of Washington, that they're estimating over $100 million shortfall by the end of September. So, that lack of protecting the commercial telemedicine will have an impact on what patients can or cannot do, just because simply people need to be seen. And, and obviously things are being opened up in phases too. So elective surgeries and dentistry and, various things are opening up, but there's been a huge shortfall in industries that were historically losing money already. So it's going to be economically a challenge for all aspects of health going forward. Garrett looks like he's excited.
I'm not clear on what you're saying in terms of like the the parity. I recall that there is a law, and I was just sort of like looking it up as we went along, that had been passed even, I see something like in 2017. It might have been, however, it applied to live video conferencing. And some of the more recent parity laws might have been including like just a telephone consultation. Yeah. So I'm not going to pretend to know for sure, but it was my understanding, because like I mentioned earlier, I'd had a couple of visits over the last couple of years, and it was my recollection that there was some parity law passed previously. But in any event, sorry.
No, I think you're right that there is a distinction between the telephone and the video full telehealth, and that the parity applies to full telehealth with video and not to telephone. Yeah.
Which is, of course, daunting because the visits somewhat were the same, with the exception of visual contact. Because you can spend 15, 20 minutes on the phone with a patient who's really ill at 2 in the morning. And of course, the insurance companies were saying, and we can get off this now, that's not reimbursable, but if you do a virtual visit, it would be. So there is some discrepancies. There always has been, there always will be, because you're dealing with insurance companies.
Right.
But as far as the efficiency goes, obviously it's going to be a challenge to bricks and mortar medicine. No question.
So shifting a little bit, and we hit on this earlier, not everything is amenable to telehealth. And so I wonder if, as you very much emphasized, Wendy, I wonder if folks can talk a little bit about cautions they might have for patients and things that they would want people to be a little bit careful about. Don, you want to get us started?
Sure. I mean, there's a few things that you can somewhat identify in telehealth, but patients with asthma, patients with abdominal pain, patients with chronic headaches, those things, patients that have injuries, concussion patients, those are patients that you can triage with a virtual visit. But as Dr. Wendy said, those are patients that eventually will have to have a tactile experience of some sort. And you know, I've talked with doctors who had patients that have fainted, and the parents have called, you know, I want to do a virtual visit about my daughter who fainted. Now you can get a good history, but as my old mentor used to say, history is one thing, but physical is also one thing too. And although you can diagnose probably 60 to 70% of illnesses by history, you're going to miss a few, and that's going to be difficult. So in the old days, when we had kids with meningitis and things like that, that would have never been amenable to a virtual visit. Nowadays, if someone calls with flu-like symptoms, they're going to have to be seen at some point if they're really serious, because we now have this multi-system inflammatory syndrome of childhood, which can be extremely serious due to coronavirus. So I'll stop there, but there are certain things that can be attention deficit, things along those lines, but assessments for developmental issues, possible autism diagnosis, those are going to have to come in at some point. And certainly vaccinations. You cannot do a vaccination in a virtual visit, and we are really behind now in vaccinating babies and toddlers because they have stayed at home and they're behind in all their childhood vaccinations. Now, the good part is they're hopefully not encountering anybody. The bad part is eventually they will.
Garrett, do you want to chime in with anything that you would be hesitant about with virtual visits?
Yeah, there are a number of emergencies in my world, particularly with spine care, like with progressive nerve injury type things that are going on. And those, I mean, I've made the attempt over virtual visits to get a sense, like if someone's got a pinched nerve in their neck that's causing their arm to be weak and numb, and I've thought they might have a certain weak muscle. I've asked them to get down and try a push-up to see, I've been able to have them demonstrate things sometimes over the video conference, but but ultimately there are cases that are progressive and that might require some sort of like surgical intervention. They have to be seen 100%, and a lot of what I do in the office, and I have some imaging on site, ultrasound imaging on site at least, and a lot of the things that I see are soft tissue injuries. And for me to best calibrate the treatment, I need to gather some data and use that imaging. So I've been having to order other tests because I'm not going in the office, MRI examinations more so. And imaging centers have remained open, so it's been possible to do. But it's interesting. I read that that this particular telehealth raises the bar of necessity in terms of ordering tests, because patients must be willing to leave their home, and it's not as easy as doing an in-office test. There are some barriers to it. I guess I would say for most of what I do, the care it's not as good as if I were in the office, and there are things that I have to shift the responsibility to trying to get testing in another way. And it doesn't, and sometimes I've had cases where, again, I've had to tell them I'm going to need to see in the office when I open. And then I have colleagues who are open who have made the choice, because I'm in private practice. I have my own little office, so we've decided to not open as of yet. And I've had some colleagues that are open that I've sent patients to for procedures and whatnot, things that are very acute.
Phil, do you want to add anything there?
Yeah, I think it's more of the same that you've heard in what I mentioned earlier. I mean, labs, obviously, vaccinations, as Don mentioned, and I do quite a few joint injections too of chronic or acutely injured or inflamed, in my case, not injured like in Garrett's practice, but inflamed. Obviously, I've joked with patients, though with my sense of humor, sometimes they don't know I'm joking, that I'm going to ship them a syringe and then I'm going to take them through the injection. And you can see the whites all around their eyes when I tell them that they're going to, I was like, no, I'm kidding. You got to come in and we got to do the injection. But yeah, I mean, and I think the other big drawback is I was talking about one of my colleagues, one of my partners and I think Dr. Don mentioned too, is that you don't get the energy back and forth. But there is something about, all of us went into medicine because we like being around people, and the flat screen is a tool, but there is a real, to be corny, but the power of the touch and healing and whatnot. And even though the patients do come in and I don't really touch them because, as far as they know, I'm gross and have COVID. So we don't, but at least being in the same room with each other for a brief time has been powerful. And as someone else mentioned, it becomes a bit of a social outlet for them. And so sometimes you have to really use all your skills to sort of end the appointment, so you're not there for 3 hours finding out about how the cats are doing and everything. So it's but I don't think that the telemedicine is ever going to replace all of our aspects of medicine, and there's just some parts that need to be done face to face.
Yeah. So there's some interesting questions in the chat that are really talking about concerns that we might have about folks making those decisions and balancing the risk and benefit of in-person care versus telehealth. And one, how do we encourage trust in telehealth, because it's a different way of doing it? And the flip side, are we worried that because people maybe don't trust, that we're going to see some real neglected health issues, that people are not going to get care at all? And Wendy, I'll let you start with dental, because that's as important as physical.
It's very interesting because my office has gone to the extreme. We've been practicing 3 weeks. We changed the air filter systems in the entire building. We had the office painted. We wear everything. That includes an N95, a mask over the N95, glasses, a shield. We change our gowns between each patient. I mean, it is as much as we possibly can do. And we are having a very successful time reintegrating. And part of it's because I've had patients for so many years and they're very trustworthy. And they also know that we're doing everything for ourselves and for them, and that it's important to us. And we're trying to track and trace so that if someone has a challenge, we know how to deal with it. And I think that we are going to deliver medicine. It's not going to, medicine and dentistry, of course. It's going to be different. It's a new normal. And we're just navigating because, as we all know, I mean, I thought by the time we were going back to work, we'd have testing and that our patients would have a test wherever it was and it would be 15 minutes and then we would know. And we do not see that. So we have to deal with what the new normal is presenting. And I think it is so unusual that I would have a new patient that's not going to see my face. Like they have to go on the web to see my face. That's very, especially my personality, it's very hard because I want to just go like, hello, how are you? What's going on? So we do it, but in a different manner. And all of us are doing that in a different manner. So the patients that we already have that we relate to, that's very special now. Because when you see a new patient, you're not going to have that same connection right away. So there's some interesting challenges, and there's also amazing, amazing patients. I had a 95-year-old that I really didn't want to come in. She took her picture. She sent me her picture. She broke her 2 front teeth, and she wasn't walking around like that. That's it. So she took some risk by coming, but we did it in the morning, first thing Monday morning, and how we clean rooms is very thorough. And I put her teeth back together and she felt like I gave her life back together because she couldn't eat. So there is some risk and how much you're going to take to fix what you need to fix. So, and it's great that you all are practicing telemedicine because I think there are people who really need to talk to someone and need to figure out how to solve their situation. And I think it's here to stay and it'll just transform as we go along.
Anyone else want to remark on the trust factor, both in terms of how we engender it and how we encourage maintenance of the healthcare that our patients need?
Well, if it's a new patient, as Dr. Wendy said, and I can certainly vouch for the sterility and the disinfecting process in her office because I felt very clean going in and even cleaner going out. But the trust thing is just engendered person to person. And although, you know, when you see a new patient, they're evaluating your ability to listen, to be caring, concerned, compassionate, and connected. And that's the way you have to be on these virtual visits as well. And the one downside I see for doctors is that it can be an exhausting process if you're doing virtual visit after virtual visit after virtual visit. When you did room 1, 2, and 3, as Lelach can validate, you had this brief moment where you were, you know, out of the room, you were considering where I have to be with the next patient and going in and you were starting fresh. With virtual visits, are you allowed to get up in between visits? I mean, the doctors have said to me that after 2 hours of virtual visits, they are exhausted. It's an efficient economic ecosystem, but for doctors, they're not connected with anybody but patients, and they're missing the social connection of the nurses and their fellow colleagues in the office. So that has been a downside for them. Doesn't mean they're not any less efficient on the visits, but it is a downside that I think we have to take into account.
I guess I can add one other bit to that is, you know, I know University of Washington is, you know, partnered with Zoom to do this, but they don't have an off-the-shelf Zoom that's going to get Zoom bombed or what you hear about. It's, you know, it's got a HIPAA compliant component that obviously still, I'm sure there's hackable components to that. I am not a technical person at all, so I can't speak to the quality of the security in it. But I can tell you, no one in our office has ever had one of those bombs that have happened in it. So in terms of the trust of the software and your privacy, I think it's at a pretty high level. Zoom doesn't want to lose the business, so I think they're working hard along those lines. And I'm blunt with my patients too, as if they're really worried that the Russians are going to find out that they're on methotrexate, I'm not sure we care. But I appreciate there's more sensitive issues than that that are discussed every day in people's health offices. So I don't want to make light of anyone's security in their, but I've felt very secure in doing my visits that way. And I just and there's an added element in my office too, because many of my patients are immunosuppressed. So asking immunosuppressed patients to come into an office, and so I've through the electronic medical record, there's a messaging system, and so I've had a lot of emails back and forth about the safety of coming in, or just the safety of them to continue to do their job on immunosuppressive medication. So that's pretty customized from one patient to the next. We have pretty extensive discussions, and I have a pretty good algorithm of whether I feel people are safe to come in to see me or safe to go continue their work at the grocery store or as a mail carrier or whatever it is. So that, I think that speaks to what Dr. Don's saying about building trust, and Dr. Wendy is, a lot of these patients I've known for a while, and so they of course know that I've got their best interests at heart. And if it requires just a quick phone call to get to that point, and then into a Zoom call, or have them come in, I think that's worth all the time to sort of have a customized plan.
Yeah, the one little comment I would love to add there is, in terms of reluctance to come in, as pediatrician, when we see kids, they don't drive up to the office by themselves. So every pediatrician takes into account not only the risk of their patient, but also the family that is accompanying them. And so I know in my practice, certainly, I have had some parents who are very reluctant for their own health reasons to come into the office. And so we're doing a lot of thinking really strategically about, so where is that risk worth it and for whom? And there's a question in the chat room about, is telehealth a good option for annual weld visits? And certainly for young children, very young children, we see them a lot more than annually. The stand that the American Academy of Pediatrics has taken is really to emphasize bringing kids into the office under the age of 2, because there are so many things that we really can't assess virtually, and all the immunizations that Don was mentioning earlier cannot be done over the screen. And so we're bringing in those kids, and we're bringing in the kids who need their vaccines before kindergarten and before middle school. And then really the other kids, if they don't have a concern that we really need to lay hands on, we're encouraging those folks to stay home and interact with us by telehealth to minimize the risk to them and to their family members. And I don't know, no one on this call does annual visits for adults, right? So I guess what I'm seeing in my office with that is a lot of the ACVs, the annual health visits for especially the older individuals on Medicaid, or Medicare, excuse me, are all being done by telehealth. And my colleagues who see those patients feel like they are very effectively done on telehealth. There's a very long process that their staff does first. So our medical assistants and nurses are spending between 30 and 45 minutes on the phone with each of those patients prior to the physician getting on, and discussing everything from substance use to whether or not their electrical bills are in danger of not being paid. And then the physician is getting on. So they're doing, I think, really a fantastic job of addressing whole person health with older individuals, and doing it really well through virtual visits.
Well, can I just say something here about to parents who have teenagers? Teenagers should come in for annual visits, not just when they're 11 for their vaccinations and then in the future, but we can do a lot with teenagers if indeed we can see them privately with a virtual visit. The acronym for teenagers heads, home, education, activities, drugs, sex, substance abuse, all of those things can be discussed in a virtual visit. What we can't discuss is what stage they're in terms of their sexuality, in terms of identifying that with an exam, and that can come afterwards. But we really want to make a plea for teenagers to access virtual visits with their pediatrician that they have confidence in and where their medical home is, because they have a lot of issues now where I don't think there's any demographic that's lost more than teenagers in this coronavirus crisis in terms of their hardwiring for social activities,
Yeah,
being with
true.
friends, identifying with their peers, trying to separate
Yeah.
from their parents, et cetera. I'll stop here. So please, if you have a teenager, schedule a virtual visit with their physician and let them just talk with their physician about where they're at,
I agree.
why they don't have a summer job, and maybe college isn't gonna happen, and should I take a gap year? There's just lots of issues.
As the parent of teenagers, Garrett is saying yes.
I got one of them.
Okay, well, I won't give you my number.
Oh. Do any of the rest of you have similar sorts of pleas that you want to put out there of folks that please, please, please do come in, do not neglect X, Y, or Z? Is there a vulnerable population that you're seeing that you want to really make a pitch to?
I'll make even a broader pitch than a vulnerable population is, they've shown now across the United States and Western Europe that non-respiratory illness hospital visits are way, way down. My wife works as an inpatient hospitalist at University of Washington, and so they're seeing on the wards there that the non-COVID wards are virtually empty. And that's not because people aren't having appendicitis or heart attacks or adult metabolic disease type illnesses. People are too scared to come in, and so they're staying at home and they're getting to a critical state, and so they're coming in crisis over and over again. There was an article on NPR that at a surgery center that all the appendicitis cases they're seeing were in incredibly advanced stages, and their patients were too sick for surgery, so they had to be admitted anyway. They had to be quote unquote cooled off on antibiotics until they could get to a more stable state before they could have their surgery. That would have been a much more straightforward, simple, one night in the hospital kind of situation. So my plea more is the hospitals have figured it out. I can speak from personal experience with my wife and how they handle it. And they really have a special pathway for patients who have a respiratory illness and are going to be ruled out for COVID-19. And then everybody else goes down a more traditional pathway of being evaluated in the emergency room and admitted, and if appropriate, and admitted. And they won't admit you if it's a soft call. If you need to be admitted, it's good to come in and get treated before it gets to a critical stage and then you're at home and critically ill. So that's a more broad plea because there are plenty of vulnerable populations out there that should be specially considered as well. But people are staying home and suffering is the short sum of that.
Yeah, I don't mind adding that something more specific than what Dr. Moberg was just saying, but just that a large percentage of the patients I see will reach out to me because they want to be active and they're having a hard time continuing to be active. And I certainly, in this time where we're staying home, it's really important to continue to get your physical activity. And we consider in my field, exercise is medicine. I actually rarely prescribe anything except for exercise. So I absolutely can help folks, in a video visit to calibrate their physical activity level so that they can maintain, help to maintain the remainder of their health, the physical and mental health. So I would put that plug in, I guess.
Great.
I
Thank
just
you.
want to say one last thing, is that certainly we're not going to lose this. The future for medical visits is going to be a blend of in-person visits with synchronous virtual visits. There's no question about that. And there was a question about, seniors and carotid arteries. Eventually, we will have remote monitoring.
Yeah.
So we will be able to listen to hearts, listen to lungs in a very unique way. That's what I'm going to call the new abnormal. And eventually we'll have portable ultrasounds, just like we have portable defibrillator units. That's going to happen. In the meantime, we have to jury rig the system the way it is now. And it's not perfect, but it's the best we can do under the circumstances. So there's going to be glitches. I think we all have to live with that, but I think both patients and doctors are doing the best they can.
And you know what? I would love to just say that what an individual can do for themselves, and it can be the whole body, is if you need help, you got to reach out. Call your physician, call the dentist, whoever it is. They're not going to set you free without doing something for you. And I think that that is the message now, especially with telemedicine and talking on the phone and reaching out to your dentist, is that we can help you at least get to where you need to go. And if it's in our office, it's one thing. If it's at another office because some other individual may be able to help them or do tests, then that's the really appropriate thing. So I think telemedicine has made that more obvious if people want to reach out.
Well stated, all of you. I think there is no stupid question. Call. We are all there, whether we are there at our home offices or in our actual offices. And we all want to hear from our patients and get you where you need to go.
I just want to say really quickly, I am so excited about what Dr. Wendy has been saying, because to me, it is not intuitive to think that, you could interact with your dentist in a useful way in this kind of a, teledentistry visit. And the idea that you could, be taught how to take the right kind of photograph, as you said earlier, and get help that way, I think is spectacular. So I'm excited. Thank you.
Okay, and it was really fun to see you all. Amy, thank you.
I want to thank all of you again, and thank you for making time. Garrett, thanks for this great idea. I think everybody on the call has benefited from your wisdom. And as I said, it's being recorded, so it's always there for reference. And Lelach, thank you so much for joining us as a moderator and lending your additional insight. This group is great. You represent a broad spectrum of practitioners. So thank you very much. Thank you for all you do to keep our community healthy, and have a wonderful evening, and everybody stay healthy. Take good care.
Thank you. Bye.
Thanks, everyone.
Thank you.
Bye, everyone. Nice to see you.